Good morning, guys. So today we'll see about sedative hypnotics. Clear? So this is general quote. It does not matter how slowly you go, as long as you do not stop. All the best, guys. So we'll discuss about sedative hypnotics. Clear? So sedative means what? Sedative na they induce drowsing, whereas hypnotics they induce sleep. Now together, sedative hypnotics they are central nervous system depressants. Okay, so the major amino acid present in the brain is GABA. Okay, gamma amino butyric acid. Okay, so we'll see how this GABA will depress your brain. Okay. So the GABA A receptor, which is present in the chloride channel. Now this chloride channel is present in the neuron. Okay. If you take a neuron, there is a chloride channel and this GABA A receptor is present on the chloride channel. Now what happens when GABA comes and binds with this GABA A receptor present on the chloride channel? This binding will lead to opening up of the chloride channel. When this opening occurs, the chloride ion gets entered into the neuron. Remember, this chloride ion is a negatively charged. When negatively charged ions are more in the neuron, this leads to hyperpolarization. Okay, when there is hyperpolarization, the brain does not work. So the brain gets depressed. Okay, clear with this. So this is the mechanism how GABA will cause CNS depressants. Okay, or CNS depression. Now in chloride channel இந்த GABA A receptor மட்டும் இல்ல நிறைய receptors இருக்கு. So there are also other receptors such as barbiturates, receptor for barbiturates, receptor for benzodiazepines. These receptors are also present on the chloride channel. Okay. Now we'll see the difference between these barbiturates and benzodiazepines. If we take the barbiturates, as you see here, they are GABA mimetic. What is GABA mimetic? Is that these barbiturates are similar to the action of GABA. Whereas benzodiazepines, if you take, they are GABA facilitatory. What do you mean by GABA facilitatory? Suppose when benzodiazepine come and bind with the benzodiazepine receptor, this binding will not lead to opening up of the channel. This binding, what it does is that this binding will facilitate GABA to open up the channel. That's why the benzodiazepines are called GABA facilitatory. And if you take the channel opening duration will be increased in barbiturates, whereas the frequency of channel increases in benzodiazepines. DRC is nothing but dose response curve. If you take the dose response curve for barbiturates, it will be steep, whereas the dose response curve for benzodiazepines is flat. However, this is safer. Okay, barbiturates, they are powerful enzyme inducers. What I mean by this is that powerful enzyme inducers in the case they'll cause more drug interactions, whereas benzodiazepines, if you take, they don't induce enzymes, so the drug interactions are very rare. Now if you take the barbiturates, they have high addiction potential, whereas benzodiazepines, they also have high addiction potential but less when compared to barbiturates. Okay, barbiturates causes severe anterograde amnesia. What is anterograde amnesia? Amnesia na memory loss. What is anterograde amnesia அப்படின்னா they lose the ability to create new memories after the event that has caused amnesia. Okay, so amnesia நடந்ததுக்கு அப்புறம் புதுசா நடந்த எல்லாமே அவங்களால ஸ்டோர் பண்ணி வச்சுக்க முடியாது. So that is the case of anterograde amnesia. If you take benzodiazepines, they also cause anterograde amnesia but less when compared to barbiturates. Okay, if barbiturates goes overdose, there is no antidote, whereas in benzodiazepines the antidote is flumazenil. Remember this, flumazenil. This is the antidote for benzodiazepines. Now, so on comparison, we came to a conclusion that on benzodiazepines has more advantages, so we'll use that. So if you take benzodiazepines, diazepam, nitrazepam, flurazepam and flunitrazepam, these drugs comes under benzodiazepines, we'll see. So the major disadvantage of these group of drugs is that they produce anti-metabolite. So what is anti-metabolite? Suppose I am giving a patient diazepam. This diazepam will cause sedation for particular hours. After this, the diazepam gets metabolized to oxazepam, which again lasts for some more hours. Okay, so the patient will be under sedation for long hours. So they are long acting. Because of this anti-metabolites, they are long acting. If they are long acting, suppose I'm giving the patient diazepam, this gets metabolized to oxazepam, and after that, even if we wake up the patient will still have that drowsiness. So that you call it as hangover. Okay, so this long acting hangover, these are all because of the anti-metabolites production. Okay, now this is avoided in elderly. Why? Because they are long acting CNS depressants. So this is avoided in elderly, and it is contraindicated in liver failure. Why? Because this benzodiazepines get metabolized in the liver. If there is any liver failure, then this benzodiazepines can become as toxic. Okay, so this is about this. So what we decided then, we want the drug which do not produce anti-metabolite. Okay, so then we went to short acting benzodiazepines such as temazepam, oxazepam, lorazepam and estazolam. These drugs, see, they do not form anti-metabolite, they are short acting, have less chance of causing hangover, it is safe in elderly as well as in liver failure. Okay, now we saw the barbiturates and benzodiazepines, how it will cause that sedation and all. If you take barbiturates and benzodiazepines, they will of course increase the sleep. Okay, so sleep nale namakku enna nyabam varudhu, sleep has two things, that is REM sleep and non-REM sleep, that is rapid eye movement sleep and non-rapid eye movement sleep. Under non-rapid eye movement sleep, there are actually four phases, right? Okay, so if you take the uh, if you give barbiturates, and suppose if I am giving benzodiazepines to the patient, then what occurs is that they'll not increase the duration proportionately for all the four phases. They'll only increase the duration of phase 2 of non-REM sleep, whereas the other phases will be same duration. Only phase 2 will get increased in duration. So by this we can conclude that the sleep quantity is increased, however, but quality gets compromised, because if it occurs, it should occur in all the four phases, then only quality remains the standard. But here the quality gets compromised. So sleep quantity is increased, but quality gets compromised. This phenomenon you call it as distortion of sleep architecture. This is caused by our benzodiazepines. Okay, now if you take a normal patient, they'll become asleep after 15 to 20 minutes. If you take the insomnia patients, they'll take 1 to 2 hours to fall asleep. So what we are doing in order to reduce the onset of asleep duration, we are giving benzodiazepines, right? So this duration which is taken by the patient to fall asleep, you call it as latency period. Now, when we give benzodiazepines for this insomnia patient, what happens is that latency period decreases. So this is advantage, but this distortion of sleep architecture is a disadvantage. So what we did, we want a drug which should not affect the quantity and quality. However, the latency period should be decreased. So then we went to Z group of drugs, which include zolpidem, zopiclone and zaleplon. This is the drug of choice for insomnia. Here the hangover is absent. It decreases the latency period, whereas quantity and quality of sleep is not affected. Okay, so S-zopiclone, it is a isomer of zopiclone, which is also used for insomnia. And this is non-benzodiazepine hypnotics. Why I'm saying is that the Z group of drugs act similar to the benzodiazepine. Okay. However, their structure differs. Chemically, their structure differs. So that's why I'm calling it as non-benzodiazepine hypnotics. Okay. And the antidote for benzodiazepine, as I already mentioned, flumazenil, that is again antidote for Z group of drugs, flumazenil. Okay. Now the next drug, which is melatonin. Melatonin, as we all know, it is um, secreted by the pineal gland, and its function is to regulate the day and night cycle. It produces sedative effect. Okay, melatonin receptor agonist includes rameltion. Okay, so rameltion is a melatonin receptor agonist. It is non-addictive, but it has very poor bioavailability. On overdose of rameltion, it causes psychiatric side effects. Now the next drug is orexin receptor blocker. What is this orexin receptor? This orexin receptor is secreted in brain. Orexin is secreted in brain. Once if I stimulate this orexin receptor, what happens is that the patient will become awake. Okay, so what we should do, we should block this orexin receptor in order to use it for insomnia to cause sedation. So that's why we are blocking orexin receptor. So the drug is suvorexant. Okay. Now there comes a question, classify sedative hypnotic drugs, write the mechanism of action, therapeutic uses and adverse effects of benzodiazepines. So see, this is a classification of sedative hypnotics. We have classified into 4: benzodiazepines, barbiturates, non-benzodiazepines and other hypnotics. Now benzodiazepines, again we have classified into 3: hypnotic, anti-anxiety and anticonvulsant. Okay, so under hypnotic, what all drugs can come? Remember as DN left. Okay, DN, that is diazepam, nitrazepam, left lorazepam, okay, flurazepam, temazepam. So DN left and AT, alprazolam, triazolam. Under anti-anxiety, remember the mnemonic as DOLAC, D-O-L-A-C, diazepam, oxazepam, lorazepam, alprazolam and clonazepam. Now coming to anticonvulsants, clonazepam, clobazam, diazepam and lorazepam. Under barbiturates, we have classified into 3: long-acting, short-acting and ultra-short-acting. In long-acting, there comes phenobarbital. In short-acting, pentobarbital. And in ultra-short-acting, thiopentone and methotrexate. Under non-benzodiazepines comes zopiclone, S-zopiclone, zolpidem, zaleplon and etiazolam. Other hypnotics include triclophos, melatonin, rameltion and suvorexant. Now this is a mechanism of action of benzodiazepines. What is that? If you take this picture, there is a central chloride ion channel and the GABA unit, which is composed of 5 subunits, 2 alpha subunit, 2 beta subunit and 1 gamma subunit. So what happens when GABA comes and binds with this GABA receptor? There causes opening up of this ion channel. Chloride ion enters into the neuron. So remember, this chloride ion is a negatively charged ion. If there is more number of negative charge under the neuron, then it causes hyperpolarization and decreases the neurotransmission by inhibiting the formation of action potential. Clear? Now the benzodiazepines, they are present. Okay, benzodiazepine receptor is present between the interface of alpha and gamma subunit of GABA. Okay, between these two, there is a benzodiazepine receptor. When benzodiazepines come and bind to this highly selective benzodiazepine receptors, it facilitates GABA to open up the channel. Okay, so this is the mechanism of action of benzodiazepines. Now coming to the pharmacokinetics of benzodiazepines, the absorption is oral, distribution is throughout the body and penetrate into the CNS, metabolism takes place through liver and excretion through urine. all benzodiazepines, remember, they cross the placenta and may depress the CNS of the newborn if given before birth. If given before birth, they will cross the placenta and they will depress the CNS of the newborn. See, some of the benzodiazepines, they may form active metabolite. As I said already, diazepam gets metabolized to oxazepam in some cases. So because of this metabolite formation, what happens is that they are long acting and they causes hangover. That is the thing, prolongation of effect or unwanted daytime sedation. This is pharmacokinetics of benzodiazepines. Now coming to uses, the main use is that it is used for insomnia. Remember, the benzodiazepines decrease the latency period and increase the duration of phase 2 of non-REM sleep, thus cause insomnia. And it is also used for anxiety disorders. It is used for epilepsy and seizure states. Diazepam is used for status epilepticus, febrile convulsions, etc. And for muscle relaxation, diazepam is used. Benzodiazepines are also used for sedation and amnesia before and during medical and surgical procedures. It is also used for pre-anesthetic medication, and it is act as a component of balanced anesthesia. Intravenous or intramuscular anesthetic is midazolam. The benzodiazepine which is used for alcohol withdrawal is chlordiazepoxide. Okay, so this is the use. Okay, now coming to the adverse effects of benzodiazepines, they cause drowsiness, lethargy, daytime sedation, anterograde amnesia. As I said already, they lose the ability to create new memories after the event that has caused amnesia, and tolerance to anticonvulsant action develop rapidly. Withdrawal symptoms occurs on discontinuation. Withdrawal symptoms include anxiety, insomnia, malaise, tremors, etc. Contraindication, as I already said you, contraindicated in liver failure and in elderly patients. So this concludes about benzodiazepines, and also this finishes sedative hypnotics. Okay guys, thank you for listening and be safe.